JNU as an atmosphere where people come from different parts of the country, they learn and they occupy themselves, they have to distinguish themselves.
The university was conceptualized as not something which is providing fragmented knowledge. The university conceptualized teaching and learning as problem-oriented. So the mandate was that they will have groups and not departments. They will have study centers which will not be discipline-based. They will be problem-oriented. And so schools were set up with kind of problem-oriented centers which were linked to each other.
So that means you have to build up a new body of knowledge built on what I could do in NTI and in NEI, but entirely different so that it fits in with the JNU philosophy of social orientation of our academic program, not disciplinary orientation. Mm-hmm. Number two, we always said this, because it is social orientation and discipline orientation, it has to be interdisciplinary. And number three, we said, we are not that arrogant even then, that we will expand the borders of language, borders of knowledge beyond, because we are interdisciplinary, we are looking into sociology, psychology, anthropology. We are also looking into health economics and the role of our own economic center doing our own sociology, social system.
The center was created with the understanding that medicine needs to transform itself, that though earlier efforts have been made within medical colleges through PSM departments to make medical training more comprehensive, more integrated, bringing in issues of common people, it succeeded only partially. It didn't achieve the kind of ideas that brought the departments into being. And it was at that point thought that if we put this department outside the medical colleges, in a different context, maybe it would be a better experiment. So, given the fact that the whole university was experimental, the Center of Social Medicine was created, and its mandate was to be problem-oriented, to relate to the health problems of the common people of this country. This department, this center should bring in social sciences as an equal partner in defining the problems of health in this country. So it shouldn't be a junior partner as it was in medical colleges, And therefore the striving was that, we work together as a team. We create new knowledge through interdisciplinary work, and that we put social science teaching and medical teaching together in a way that maximum possible interaction is available. So that was the mandate with which we started.
Who's position, I think, in which Dr. Qadeer, of course, was the first And then soon, after a few months, Dr. Ramlinga Swami joined. So they were witness and participating in this exciting movement of creating an entirely new body of knowledge which suited India, which is, you can say, our जो mandate है to subordinate knowledge to the people of India. People जो भी हैं, उनके लिए हम ये सब काम कर रहे हैं. Knowledge.
I landed up here because I was told that this is an experimental place. This is a place which is trying to make medicine meaningful, and that this is a place where the challenge is of building new knowledge. So you can imagine that from the background of being a pediatrician, being with sick children 24 hours and their families, I landed up in this very new university, which was just growing. People were new. There was just too much excitement.
So if you go into the inner history, similarly, जैसे हम कह रहे थे, जब हमको बोला जीपा सर ने कि we want to do postdoctoral work beyond doctorate in the center of social, मैंने कहा तो बहुत अच्छी बात, because that's what I was looking for. But then actually क्या हुआ? After some time in the School of Social Sciences, वो बोलने लगे भाई हमें तो मास्टर्स करना पड़ेगा, एमए करना पड़ेगा, कि नहीं तो काम नहीं बनता. स्कूल ऑफ लाइफ साइंसेस बोलता है वी विल टीच आवर ओन स्टूडेंट इन एमए एमएससी. अरे तुमको तो हिंदुस्तान में काम करना है.
The content of this center developed over time. So what I'm trying to say is that we were given with a mandate. Different centers made different things out of that mandate. Some were highly discipline oriented, some tried to do interdisciplinary work and had their own set of challenges. We were a small center to begin with. I'm sure we were seen with a lot of skepticism in the school. What are these people doing here? We were not social scientists, except for Professor Ramlinga Swami. Then over time, through interactions, through learning, we have managed to develop a set of courses. Now, the early courses were, I can now look back and say that, we were still very segmented. And we tried it on students, and a lot of learning and realizations came through time, through teaching. For example, what kind of social sciences are you going to teach? You can't teach anthropology, sociology, politics. You can't do that. So what is the meaning of being problem-oriented? So the first thing that we had to define is that within public health, how do you create a focus? And therefore the importance of epidemiology. The second thing we defined is that, okay, if these are the key problems which we want to address as priorities, then what kind of social sciences is required? So what will you draw from sociology? What will you draw from anthropology, from economics? Any discipline that you want to take on. And therefore the nature of courses changed. For example, I started teaching with nutrition. I'm sure in the beginning I was very biomedical because that's what I knew, that's what I could teach. But it's only through interaction with social scientists that the course transformed itself, because it could not talk of nutrition without relating to production processes, without relating to distribution processes, without relating to policy. And so then the whole thing of differentials within the nutritional status, and how come these differentials are coming, and so what is the social root? So you go into a whole set of concepts of caste, class, gender. So similarly in all kind of areas, the importance of understanding that you have to draw selectively from disciplines, and in the third stage also understanding that social science itself needs to be integrated. You can't draw like this from here and there. And how do you integrate social sciences? So the importance of having your perspective. How do you create an overarching perspective, and what is the philosophical binding between different concepts?
ये जो न्यू ग्रामर है, social sciences as a whole and endogenously produced social sciences, not the American produced or the British produced. जो हमारे श्रीनिवासन साहब थे, श्रीनिवास, वो तो कैम्ब्रिज के थे, और कैम्ब्रिज में social anthropology, peculiar word, which is now in Delhi University, was to help the colonialist to know the colonial people so that to extract more. इसको कभी श्रीनिवास को समझ में आया? I saw him. बोले Banerji, we are not in applied things. Srinivas was one of the most outstanding. So, yeah, I'm talking social sciences, but we can also talk of technology. क्या technology हम लोग use कर रहे हैं? Our Prime Minister, every other technology हम use करेंगे. अरे करो university, nobody is saying no technology. But technology must be subordinate to the needs of our people. This question of a new grammar in public health. So when we do new grammar in public health, Dr. Zubia, we are not ignoring almost PSM, preventive and social medicine. क्या दूसरा नाम community medicine. Someday Dr. Wig, the director of IMS, says इसको preventive and social medicine बोलो, इसको बोलो community medicine. Medicine become under the clinical look, and that is what we are having, today. Whole system of medical education, including MPH, including DTM. So, ये जो new grammar है, is a new thinking.
If you talk of the positive things of the center, I think the projects that we did together, where the entire faculty was involved, where we interacted a lot with each other, contributed a lot to the growth of this process, because faculty interaction is a very important thing which we try to develop. There is no end to it. It has to keep evolving. It will change. Its forms will change, but it cannot be ignored. Because it's only through working together. If you in your own group work together, then your interaction with outside become better. So we were able to draw also from other centers like economics, Center for Social Systems, regional development. These were the centers which we started working with. Then science policy came in. Policy became an important part of studies here. One of the contributions, I think, of the center till that period was that a lot of institutions asked us to send us actually what courses are you teaching. And they build their own courses on the basis of that.
Because after Mahler, I think I have quoted in my autobiography, we learned from you. He was the chief of the WHO group in Bangalore. But he said that we want to learn from you. And that when Mahler went on to become the Director General of WHO, and Mahler and his group, not I, they thought of the Alma-Ata Declaration on primary health care. They imbibed, they drew on the knowledge they had imbibed through our work in Bangalore. And Mahler has always admitted that. Admitted means not he respected the NTI, the sort of a thinking we followed. Although they were WHO people, so we said nothing to it. We are to depend on the data that we have. And where we produce data, what we call the social dimension of epidemiology. This is the very essence of interdisciplinary.
Personally, I believe that it was not a question of engaging with the Alma-Ata process. I think we were a part of Alma. I'm sorry, I may sound a little this thing, but I think we were a part of the Alma-Ata process. We were the initial forces which started talking in a different way. And of course, Professor Banerji was there within WHO. He was a very influential force. And then the kind of work that the center was producing on primary health care, on the challenges to which different people were writing and contributing.